Well, we are live now, sir.
Um, Thank you. Uh, Good morning, everybody. Welcome to another session on the pediatric foot module. Today we have Dr. Matthew Varghese. He'll be taking a class on neglected clubfoot and relapsed clubfoot. And on behalf of the OrthoKids Clinic and the Fellows Teaching module, we are very grateful to Sir for taking out his time and joining us today. Sir is an alumnus of Maulana Azad Medical College, New Delhi, and Sir has been in St. Stephen's ever since then. And for almost 4 decades, Sir has been there. He was an ex-director of St. Stephen's, and currently Sir is the head of the department there. And Sir's work on eradication of polio has been recognized internationally, and Sir is involved in a lot of postgraduate teaching courses in the north. And even when I was doing my post graduation in CMC Ludhiana, I could attend one of his lectures in the MAMC PG teaching course. And sir, we are very grateful to have you with us. So, sir, we'll start the session now. So you can share your screen.
Thank you so much for the invitation, and thanks to Maureen, and thanks to you, James, and all of you there for inviting me to this session. I really appreciate this. So I'll first start with the recognizing, and is my screen visible?
Yes, sir.
Make full screen?
Yes, sir.
So recognizing and managing clubfoot relapse. So this is a shorter of the two lectures that I'm going. The second would be the topic given by you is neglect clubfoot, but I will comment on the neglected part a little later. Disclosures. I'm the Honorary Medical Director of Cure India International Trust, which is a voluntary organization. Clubfoot, whatever be the method that you use to treat, can and will recur unless you take care of the maintenance phase properly. So the treatment of clubfoot has two phases, the correction phase and the maintenance phase. Both are equally important. If you do one inadequately, the other will remain inadequate. If you do one correctly, the correction phase all done beautifully, but fail to do the maintenance phase to the duration that it must be continued, you will have a recurrence. So the process of treatment in clubfoot is long drawn out process. We have to recognize this. It is not a shortcut treatment method. And that is precisely why people did not recognize the importance of long-term follow-up. They knew it, but it's difficult to have long-term follow-up of so many patients. It's only Ignacio Ponsati who had the patience to follow them up over several years before he reported the results of long-term treatment of club. Surgical treatment gives you dramatic results. Patients are happy, parents are happy, you're happy. You've done magic, it looks beautiful. However, you wait for time. Relapse is a function of time. Remember, in clubfoot, there is a primary problem as per Ponsati in the soft tissues on the posteromedial aspect of the child with clubfoot. There is a retractile fibrosis which is there, which is stretchable, and this tendency for the retractile fibrosis remains till the child is about 4 or 5 years. Therefore, the probability of recurrence of the deformity, because the persistence of the retractile fibrotic tissue is going to remain till the child is about 5 years, will cause recurrence to. So we have to understand this. Recurrence or relapse is a function of time. Give time, it will relapse. Again, one must differentiate between idiopathic clubfoot and secondary or syndromic clubfoot. Idiopathic clubfoot is the one what we are talking about. Syndromic clubfoot and neuropathic clubfoot or the secondary clubfoot, it's a completely different baggage. Phenotypically, it may look similar in terms of equino-cavo varus deformity, but in terms of behavior, it's a completely different beast. We cannot compare the two. We cannot talk about relapse in the secondary and the syndromic clubfoot in the same way as we talk about idiopathic clubfoot. So my session today is on relapse in an idiopathic clubfoot. This is something we have to drive home. And the parents, when they come to you with a child with clubfoot, their expectation is you do the treatment, 4, 5, 6 weeks, casting, and then that minor tenotomy surgery, and the child becomes all right for the rest of his life. That's what you're given to understand as a young postgraduate. You need to have a brace protocol. Okay, no big deal, bracing for some time, but the foot is corrected. No, it's not corrected forever. It tends to come back. The retractile fibrosis, as described with Ponseti, will cause the deformity to come back. This is Ponseti's slide. Ignacio Ponseti shared this slide with his fellows, and they have shared this with me. And if you look at from 1948, he started the technique in 46 or so, 44, 46. And in 48, he started looking at his recurrences. What was the recurrence rate with the master? The master himself showed a recurrence rate of almost 49, 50%. 49%. That's huge. Ignacio Ponseti, he analyzed the kinematic coupling of the joints of the subtalar joint, the movements of the joints of the foot, analyzed how the deformity occurs, and came out of the treatment regime and knew exactly how to correct and how to manipulate and where to place his hands and how to put the cast. He perfected the technique. But from 1948 to 1984, he was following up his cases. And the blue bar that you see in this chart is a recurrence in the age groups that are shown. So the x-axis shows the age group and the y-axis shows you the recurrence rate. In the under 1 year, the recurrence rate is 49%. 49%. In the under 2 years, the recurrence rate is almost 45%. In the under 3 years, the recurrence rate is almost 40%. Under 4 years, it goes to around 30 some percentage. Under 6, it comes to 20 or so percent. So this is what you have to understand. Is the relapse rate 0 at 5 years? No. There's a small percentage of children who will continue to have. And till 84, the brace protocol was not as per the current brace protocol. From 1991, after the review of his cases, he came up with this recommendation. The corrective phase of casting and tenotomy is part of the treatment. The maintenance phase is equally important. So the brace protocol has to be continued till the child is 5 years. When I started doing Ponseti way back in 98, the recommendation was to give the brace for 2 years or so. Then it increased to 3 years. Then it increased to 4 years. The current recommendation is 5 years in children that have had idiopathic treatment. We do the correction and do this maintenance phase with the brace, foot abduction brace. We do that. And there, the recurrence rate comes to less than 15% if your maintenance phase is maintained correctly. So if a child has got what I call about subsequently in the lecture, the dynamic supination. Some of these children with dynamic supination may need a longer period of brace protocol. So remember, the maintenance phase where you put the brace in a child, the rate of recurrence is prevented only by the brace protocol being correct. So why do relapses occur? So time and again, research, peer-reviewed article after article, journal after journal is talking about failure to adhere to the protocol of brace wearing is the reason for recurrence. The protocol recommended is after tenotomy, 3 weeks casting, and then a brace. For 3 months, it's 23 hours a day. After that, it is night time and nap time. Rest of the day, when the child is up and about, walking, standing, running, doing everything else, the child does not wear any special shoe. In a field setting, in a village setting, the child may walk bare feet. The child may walk bare feet. But it's important that during the walking phase, no brace, but during the sleeping phase, because this child has to recognize the brace is to be associated with sleep. So average child, as the child grows older, sleeps anywhere from 10 to 12 hours in the less than 2 years period. And after that, it's still about 10 hours or so, 8 to 10 hours. So the entire period, that is the brace protocol that has to be done. You have to follow that. And the child's recurrence rate will happen because of maybe incomplete correction. It looks corrected, but abduction may not have been good. It looks corrected, but dynamic supination, overactive tibialis anterior may be there. Looks corrected, but there is a growth spurt and the tissues do not keep pace with the growth of the bones, and therefore there will be recurrence. There may be other reasons. What you thought was idiopathic may have been a very mild arthrogrypotic, fibrotic muscles, which causes recurrence to happen. So, cause not known. So, relapse can have multifactorial etiology. How do you prevent the relapse? Relapse is prevented by ensuring that you have the brace protocol. The 70-degree abduction brace is important. Foot abduction brace after the correction has been complete is the only way you can prevent the deformity from recurrence. Remember that. Also, when the child is wearing the brace for 23 hours, no issues. After that, when it is on a night and nighttime brace, the child has to be taught stretching exercises. And the parents have to be taught about stretching exercises. These stretching exercises will be passive stretching exercises to a child in the lap of the mother, where the whole foot is dorsiflexed. The whole foot is dorsiflexed. You stroke the sole of the foot and see, is there any supination or is there neutral dorsiflexion or eversion happening? The ideal situation is when you stroke the foot, there is eversion happening. That's the ideal. That means in a clubfoot, the baby has been in the womb in the deformed position. Outside the womb, remain the deformed position till you correct it. Therefore, the everters haven't had a chance to become normal strength. Everters of the foot are weaker than the inverters of the foot. And therefore, when you check for everters, they may be less strong than the inverters. So when you stroke the undersurface in such a child, overactive tibialis anterior can cause inversion or supination of the foot. So you need to observe the child. If the child has begun to walk, a standing, is the heel on the ground or is off the ground? Get him to the heel may be on the ground when he's standing. But when you get him to squat, the heel may rise. When you get him to walk, there'll be early heel rising. So you have to look at the relapse. The most important thing, the last deformity to be corrected is the equinus. The first deformity to recur is equinus. Usually when the foot goes into equinus, varus also comes along with it. That's dynamically coupled. Equinus posturing of the foot goes with the hind foot equinus goes with hind foot varus. So if there is equinus, there is a high chance there will be a hind foot varus also. Also look for, is there on stroking the foot overactive tibialis anterior, and that will show as a supinated foot on walking or on stroking, there is supination. So this is something which you will notice in a child. So if you have a child who's presenting with an early recognized hindfoot equinus and varus, all that you need to do is convince the parents before it actually happens, before the scores become 0.5 or whatever, you want to make sure that the child is wearing the brace. Ask the parents, is the child wearing the brace? If it is going into an adduction deformity, if it is going into a supination deformity, like the before the correction, if it's going into, it looks good on weight bearing, but the moment the child takes the foot out, the foot goes into slight plantar flexion and inversion, slight forefoot adduction. Oh, yeah, it becomes all right, it becomes corrected. No, don't accept that. You may need to ensure that the child is well. So you talk to the parents. They'll tell you, no, 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 for the last 2 months, the child is not wearing the brace properly. He learned to untie the laces and take it off. And therefore, the brace protocol period is reduced, and therefore, there is a chance of it. So in such a child, it's good to put in a period of 2 to 3 weekly casts. That the child can then be negotiated with on you choose the brace versus the cast. The child will immediately choose the cast. So a growing up child will immediately accept it. So when you manipulate and cast using the Ponsonby method, there is a correction that happens. Mild deformities will get corrected nicely. And then you move on to the corrective phase brace, the deformity is corrected well. So we need to understand this very well. Occasionally, if oneness is severe, you will need to consider a redo tenotomy. But sometimes you may not need to do it in all cases. Sometimes you may get away without doing a redo tenotomy. So we need to understand this. So you need to encourage the parents to do stretching, the child to do squatting, and there are 3 things that I tell the parents when the child has become a walking child and the adherence to brace protocol is coming down. I negotiate with the child and the parents, both of them. You decide you want a cast. Oh, no, I don't want a cast. Make sure you wear the brace. So that's where regular follow-up becomes critical. Regular follow-up to ensure there is early recognition of an early relapse appearing. So in such a child, adherence to the brace protocol will ensure your foot deformity is corrected. However, if the deformity has started actually relapsing back, then it won't work. So at that time, when it has not really relapsed, but you see there is a dynamic supination coming up, you ensure that there is squatting. The child will squat, but the heel won't touch the ground. He'll keep his feet apart. His heel will not be up. He won't squat fully. He will not bring his buttocks down. You'll have to tell the child to hold on somewhere and squat properly. Only then will he be able to correct it. And secondly, first is passive stretching. Secondly is the squatting exercises. Thirdly is walking uphill on a slope, not on staircase, uphill on a slope. That forces the foot into dorsiflexion. You have to ensure the child goes uphill on a slope. And lastly, to build up the everters, what do I tell the parents? I tell the parents, you have to use a football and kick it outside. So the left side, the foot is normal. The everters are good, but the right side, the child won't be able to kick as well. So to build up the everters, you do the football kicking on the outside. So dynamic supination is something that you check for. In the gait cycle, swing phase, the child will supinate the foot. Or that's it. Can you see that? That's supination of the foot. The foot every step into supination. That's supination. Or when you stroke the undersurface, the foot will go into supination. So again, so when you stroke the undersurface, the foot will go into supination. Stroking, there, that's supination. Whereas in a normal foot, the foot goes into dorsiflexion and eversion. There is no supination. So that's the way to check. In a unilateral clubfoot, you'll immediately see the difference. There is dynamic supination. You have to ensure the brace protocol in some of the children. You may need to continue the brace protocol beyond 5 years also. So that's important for you to remember. If there is dynamic supination in a child, ensure brace protocol and a child who's more than 3 years. Why 3 years? You can consider a tendon transfer. So there is overactivity of the tibialis posterior. To ensure that this overactive tibialis anterior is shifted to a new location where it cannot produce supination and cannot produce recurrence of deformity, we do the tibialis anterior tendon transfer to the third cuneiform. So you do choose the year 3 years because the third cuneiform 3 years. Remember, third cuneiform takes 3 years in a child to appear. Most children, somewhere between 2.5 to 3 years. It's easy to remember third cuneiform 3 years. The cuneiform is identifiable on an image intensifier. You take a total transfer of the tibialis anterior and put it through a 2-incision technique from the middle side to the third cuneiform. So that is it. So the axis of the movement of the tibialis anterior, which is medial, taking the foot into supination, is put laterally onto the third cuneiform, and therefore that's the third cuneiform that you see here in the X-ray image intensifier picture. That little dot that you see there, the white spots that you see there, that is the transferred tibialis anterior tendon. Original size by Norgrove Penny using a felt. That's my slide where I've used the tibialis anterior through an oblique incision here. Take as much length of insertion of the tibialis anterior. If you fall short, you won't be able to put it into the bone correctly. So make sure you take the full length of the tibialis anterior, dissecting it away from the, there, that's the tendon with non-absorbable stitches. Identify the medial the third cuneiform, and using an image intensifier, this is the third cuneiform, and use a pull-out stitch. So you may use a button. Buttons are usually smaller. So I usually use a gauze piece with a rolled up catheter like this. So these days I use this polyethylene catheter. The rubber catheters are not available easily. I use this catheter, hold it up with this, and stitch it up with Prolene suture, and it works like a very nice large size suture holder is important, because if you have a small button, it will cause a pressure sore. We don't want a pressure sore. So we have this, which you have a pull-out suture through the third cuneiform, and put it there, and it works, and give a cast for 6 weeks, followed by an AFO ankle foot orthosis for 3 months. That's good enough. So after 3 months, you can let the child. So this is a post-op follow-up. So several years follow-up in a child in whom good eversion is possible. Can you see that? See the tendon transfer, which is acting. See that? When the child is supinating. Again, so that's the tendon transfer for a dynamic supination. After 3 years, you don't do it in less than 3 years, because the middle cuneiform is not ossified. You cannot see the middle cuneiform inside. The lateral cuneiform is not ossified. You cannot see the lateral cuneiform in these children. So once it is identified and decided to transfer, you will be able to have a good correction. When you're looking for recurrences, please look for the sole of the foot. You will immediately notice the varus of the hind foot. Can you see the varus of the hind foot? And look at the with dynamic supination. There's dynamic supination that is there. See this? The right side foot, there is clear dynamic supination. On the left side, there is no dynamic supination. And when you look at the child, from the sole, there is forefoot adduction that is visible. There is plantar flexion that is visible. In a walking child, if the child is not putting the heel down, the heel will be smaller. And when you try to dorsiflex, the child will not be able to dorsiflex. There will be adduction of the forefoot. When you try to abduct, see that? Abduction will be restricted in these children. So foot abduction is an important constituent that you check for. So foot abduction usually consistently follows the restriction of equinus. A well-corrected foot you will be able to abduct it well to 20 to 30 degrees. An incorrected foot, you won't be able to. It may look good. It may become straight in the lateral border, but you won't be able to abduct it beyond the neutral positions. You need to understand that only then. So this is the corrected foot. The incorrected foot, you won't be able to abduct and dorsiflex like that. So this is what you do in the children. Good dorsiflexion, neutral dorsiflexion after tibialis anterior tendon transfer. Whereas on this side, there is tibialis anterior overactivity. Can you see the overactivity of the tibialis anterior? That's causing the foot to go into supination. This foot was passively correctable. The parents said, no, no, sir, it looks all right. Do you really think he needs the casting? Do you really think he needs a tendon transfer? Yes, he needs it. Because with this continued supination, he will have recurrence of all the other deformities. Then there are those cases that relapse after surgery. After surgery, the relapse is a given because all surgical procedures heal with scar tissue. And when you have a scar tissue has a peculiarity. It shrinks with time. The collagen fiber does not keep pace with the growth of skeletal structure. Therefore, as the child grows, the deformity will gradually worsen and become more and more stiff. So this foot initially looked beautifully corrected. Down the line, it is severely deformed. Can you see the degree? Can you see the length of the soft tissue dissection? It doesn't help. Extensive dissection causes extensive scarring. Extensive scarring causes extensive relapse. Please remember the sequence. It will cause excess. So goal should be to try to do that. So this child came to me with extensive scarring. Look at that. Look at the extent of the scar that is there. Look at the cavus. Look at the equinus. Look at the hind foot varus. See the varus? See the forefoot adduction? All components of deformity are there. He came to me for surgery. I said, no, I'll try Ponseti's cast. Ponseti's cast is gentle. Ponseti's cast, the chances of recurrence and scarring is less, and therefore you will be able to correct it. However, there is no clear guideline on upper age limit for trying Ponseti's method, and including tenotomy. So this child with severe scarring and recurrence, I corrected with Ponseti to this level and I did a tenotomy. I did a tenotomy under local anesthesia and see the amount of hind foot valgus that I have been able to achieve in this. See the amount of forefoot abduction that I was able to achieve. It was beautiful correction. And however, this is an 8-year-old boy getting a brace. I gave a hinge brace in these children, but the short-term result is good. What about the long-term result? He came back about and it is getting corrected. So remember, repeat Ponseti is worth it. You don't cause scarring, and the chances that this foot will remain lastingly corrected is far better. Remember that. Again, if a child comes to you with frequent recurrences and the parents insist, sir, we are very diligent with the brace protocol, sometimes you have to trust them. Quite often, you don't trust them that you don't believe that the brace protocol is good, but sometimes you have to trust them. This child came to us with a repeated recurrence despite brace protocol. So when we see such a child, and that's when we do an X-ray done. Normally, we don't do X-rays in these children. There is no role of X-rays in the unoperated idiopathic clubfoot. May be required in syndromic, may be required in the operated child. So this child had an operation for the foot for correction, and he was coming back with repeated recurrence after the Ponseti's method was done. After surgery, Ponseti's method. So when I got the X-rays done, lo and behold, what did I see? See the navicular on the right, see the navicular on the left. Navicular on the right is smaller. Avascular necrosis of the navicular. The navicular is smaller. It is not keeping pace with the navicular on the other side, and therefore the middle side is structurally short. It is not soft tissue contracture. It's structurally short because the bone is not keeping pace with the growth. We need to recognize this. So I'll stop here the relapsed clubfoot lecture. Any questions that you have on this or any clarifications?
Yes, sir. So we have questions. Once. So Dr. Varun has asked if there is a relapse at the age at around 3.5 years, what would be the maintenance protocol?
Yeah, so the maintenance protocol, we try to, at 3 years, they're not really going to school, they may go to a play school. So tell the parents play school is not a big deal. You give a foot abduction brace, and in the older child, the foot abduction brace can be a challenge. The child learns to untie the brace. So you put a lace, tie a lace on the sole of the foot and a knot that you can't pull out and untie. So little children have problem untying laces. So if you've tied it correctly, the child won't be able to take it out. That's number one. Number two, the first 3 months after the correction is achieved, you must have the brace for 23 hours a day. After that, it's only night time and nap time. Subsequently, you would notice that these children are not able to abduct it fully to 70 degree. So these are the older children, older than 3 years, less than 3, keep it at 70 degree. Older than 3 years, maybe still try 70 degree. If the adherence to brace protocol is poor, even after trying, then you may reduce it to 50 degree, but no lesser than that. So the brace protocol is nighttime and nap time continue for minimum 3 years afterwards. 3 years afterwards. That's important.
Thank you, sir. So another question is it needed to abduct to 70 degrees in all cases? Sometimes I have observed lateral
You can
midfoot crease.
abduct to 70 degree only in infants and in the younger child. In the older child, you will not be able to abduct it to that extent. But remember, on the brace, when you have a 70 degree abduction, all the abduction is not at the foot. Some of it is at the subtalar joint, some of it is at the ankle joint, some of it is at the knee joint, some of it is the hip joint. A lot of rotation happens at the hip joint. So it's important. It is important that you recognize that the child will tolerate the 70 degree abduction, though the child cannot 70 degree abduct his subtalar joint to that extent. Just remember that.
So what is your protocol for untreated clubfoot after 6 years?
I have the next lecture coming in.
Okay, sir. So one last question. What is the indication for posteromedial release after 6 years?
Posteromedial for idiopathic clubfoot, I don't do it. I don't do it. If it is not getting corrected, it is almost always a syndromic clubfoot. You don't need to do posteromedial soft tissue even at 6 years, 7 years, 8 years, 9 years, 10 years. I don't need to do it. You don't need to scar these children. Idiopathic clubfoot will get corrected. Don't put your knife on these children. There is no indication 6 to 8 years also for posteromedial soft tissue release. How long is a plaster kept after tenotomy? In a child more than 2 years, I give it for 4 weeks. More than 3 years, I give it for 5 to 6 weeks. Change, no. If dorsiflexion is achieved, then I don't change it. If dorsiflexion is not achieved, I change it every week till good dorsiflexion is achieved. So you don't do dorsiflexion without tenotomy. Dorsiflexion cast is done after tenotomy. Before tenotomy, if you do dorsiflexion, you cause midfoot break. You don't want that to happen.
Thank you, sir. So I think we do one last question. It's the site of retenotomy, sir. How to select?
Yeah. So my tenotomy site is not exactly what is described in the books. My tenotomy site is slightly higher than normal. Why? If I have a recurrence, I prefer to do it below the previous tenotomy scar. Why? Because usually when there is tenotomy done, there is bleeding. When there is bleeding, there is scar tissue that forms or the organized clot that forms there. And there is adhesions that form there. And these adhesions cause the persistence of the coinus if it is recurring. So correction becomes difficult, pop doesn't happen, and therefore good dorsiflexion doesn't happen. So what do? I prefer to do the tenotomy below. If your already tenotomy is low, when it is difficult, then you may have to go higher. You don't want to damage the cartilage of the calcaneum tuberosity there. We don't want to do that. What is the site for selection of my tenotomy? The site for selection of my tenotomy is just above the level of middle malleolus. I don't take the tuberosity as the reference point. I take the middle malleolus as the reference point.
Thank you, sir. So I think we can proceed with the next talk, sir. Then we can take remaining questions then.
Okay, so I start sharing again. Is it visible?
Yes, sir.
Yeah, the topic given in the announcement for the webinar was neglected club. So I do not agree with the term neglected. The WHO in the 90s came up with the recommendation. The word neglect goes with the connotation of blame. We are not in the blame game. As physicians and surgeons, we are in the treating game. We are not in the blame game. Who neglected? Did the mother or the mother-in-law? Father or father-in-law? Or maybe the pediatrician, or maybe the obstetrician, maybe the orthopedic surgeon, maybe the medical superintendent, where the orthopedic surgeon was hired, or maybe the health secretary who allowed the license for the nursing home, or maybe the health minister who allowed the health secretary to allow the licensing procedures, or maybe the chief minister, or maybe the prime minister who allowed this to happen. Where the buck stops. We don't want into that. We want the child to be corrected. So we do not call a neglected clubfoot as a neglected clubfoot. We call an older walking child an older non-walking child. Older walking child partially treated or treated with relapse. We use those expressions. So please don't use the word neglect. Disclosures, my disclosures remain the same. I'm Honorary Medical Director for Cure International India Trust, which has a goal of trying to prevent disability from clubfoot, and Run Free 2030. Run Free 2030 looks at accessing clubfoot to every child, quality clubfoot treatment to every, which is Ponseti's method, to every child born with clubfoot around the world. So it's a global target, Run Free 2030. So we look at it from that perspective. Ponseti's treatment is accepted as the gold standard for less than 1 year. But older than 1 year, do we have any guidelines? So when I started doing Ponseti in 1998, that's almost 26 years back now, there were no recommendations for the older child. I was so happy with the results of the children that I was doing with Ponseti's method. I was excited. This is one clinic of mine. See this clinic? One clinic. I didn't plan this picture. When I looked out, I suddenly saw all these age groups. I said, oh my God, from 6 months to 15 years, all are there. And all of them can be managed by Ponseti's method. I do not have to operate any of them, assuming they are all idiopathic clubfoot, and they were all idiopathic clubfoot. All of them were taken up. So we started initially as a thesis for a postgraduate of mine way back, where this was done. And we initially chose 2 to 3 years. And at those days, we were doing a full evaluation of these children, photographs in all of them, photograms in all of them, X-rays also to check pre and post-op. So look at that, pre-op X-rays, pre-Ponseti X-ray, post-Ponseti X-rays, pre-Ponseti photogram, post-Ponseti photogram. We did the full works. And we were fascinated with the results. So good. Correction was so good. Then we started extending it to 6 years. Now we try Ponsetis in all age groups, 12, 14, 15, 16. In the older one also I do it. Why? Because the magnitude of surgery, the magnitude of dissection that I have to do in correcting them is much less. Trouble comes when somebody has put a knife to that child's foot. If the knife has been put, then it is scar tissue. And scar tissue is inelastic. Scar tissue does not stretch easily. We have to remember that. So in the older child, let's understand what are the problems. In the older child, the problems are in evaluation, in manipulation, in casting, in tenotomy, in bracing, in outcome evaluation, and in follow-up management. Each component of treatment, the Ponseti's method, has a problem. Let's look at them one by one. Problems in evaluation. So what do we do in a child that comes to us as an infant? The Pirani score is a validated score as the infant. Is it validated for the older child? No. Is it useful for the older child? Yes. We still use the Pirani score in the older child, but we know what is not valid. We know that the medial and the posterior creases are not very valid. We also note that the empty heel sign is not valid. We know that the curved lateral border is valid. We know that the talar head reduction is valid, and a failure of reduction tells you it is not corrected properly. We know these little nuances. Is the empty heel sign valid? No. So Dr. Pirani came up with researchers at the Karolinska Institute in Sweden. They came up with the Pirani-Baum-Sinclair score, PBS score, Baum-Sinclair score. So this is a published in the Journal of Children's Orthopaedics 2019 article, which has a 7 to 18 scoring system, which looks at child in different levels of activities. A static examination and a dynamic examination. The child is allowed to squat, allowed to stand, is allowed to walk, do active dorsiflexion, active plantar, look at the whole thing and then come out with it. However, there are challenges to do this, and it is difficult to do it in a smaller child. They will not cooperate. They want to walk the way they want. So for purposes of convenience, we do the evaluation by using the Pirani scoring. Manipulation in the larger foot, because the foot size is larger. So if it is a smaller foot, I can do this manipulation. So this is the one hand manipulation. One hand in the metatarsal first ray, the other hand is on the talar head. But if it is a large foot model like this, I can't do the same thing. I can't get my finger to the first ray and the thumb also on the talar head. So then I have to use the two-hand maneuver where I use it for molding and manipulation. So that's the challenge. The two-hand manipulation has to be done. Casting again is a big problem. So the child operated clubfoot that I showed picture in the earlier lecture, very clearly this child, when I saw initially 2-3 casts, no correction was happening. So then I noticed after the 4th cast, correction started happening. So we started watching this and find that initially if there is no correction, don't worry, it will happen. Number one. Number two, if it's still not happening, re-examine the cast when the child comes back to you. Maybe he comes with a totally battered cast. So you may need to reinforce with a synthetic cast. So in these children, we reinforce with a synthetic cast. In the first child, we gave cast at 90 degrees. But at the end of the casting procedure, which is about 12 weeks after tenotomy and the casting, 90-degree immobilization caused the child to have a painful knee and extension was restricted. So after that, we don't give 90-degree cast, we give a 40 to 60 degree depending on the age of the child. At 40-degree flexion, the child can with boots go to school also. No issues. So I do one at a time. That's a battered cast. Can you see that? This cast is useless. You can have 10 of these casts and it's still not corrected. You can't do that. So we do reinforcement with these. I use one plaster for 2 of these children. And if it is an older child, we use one synthetic cast between 2 of the feet if you're doing bilateral. First few casts may not show correction, but reassure the parents on this. We use weekly change of cast. We don't do 2 weekly. Literature says 2 weekly cast. This is unnecessarily prolonging the fracture disease, the plaster disease. We do not want to prolong treatment. Week is sufficient. The protocol of week is convenience for the clinic. Protocol of week is convenience for the patient and the family to remember when to come back. If you give a 5-week accelerated paucity, there is confusion. First time is coming on Monday, then Tuesday, Wednesday, Thursday. Next time is coming on Saturday. The next visit is coming on Friday. The next visit is coming on every Wednesday. So you keep changing the dates. It's confusing to the parents, confusing for you. Of course, if you're a single practitioner sitting in one small clinic, you may manage it, but then that's not necessary. Tenotomy. There are no guidelines for the age limit for tenotomy. Do I do it in the older age group? Yes. Earlier, I was doing TA lengthening. I no longer do TA lengthening any of these older children. All of them going for a tenotomy. There is literature support. There is no need for posterior release. Posterior release leads to scarring and recurrence rate is there. I always do it under local. There is sufficient literature evidence up to 9 years for tenotomy. What is the oldest patient you know? I have done tenotomy, 40 years old. I do tenotomy. They all regenerate. The authentication of this technique is that article which has come up in the Journal of Bone and Joint Surgery large number of patients treated in the UK with ruptured tender Achilles treated conservatively. The conservative results were better than the operated results. So the tendon that is cut regenerates beautifully. I've gone back in some of my own cases for other reasons. I had to go back and I find that it's a full thickness regenerate. Again, in a previously tenotomized case, the equinus never corrects fully. You never get the pop. So what do? You cut the tendon, call the child back after a week for a weekly dorsiflexion cast. You don't do a dorsiflexion cast. Thou shalt not dorsiflex. That's the commandment that you have. After tenotomy, you may dorsiflex. Because the toughest structure is the tender Achilles. That doesn't let go. The ligaments give way. You have a rocker bottom foot. To avoid that, after tenotomy, the tougher structure is gone. Now you're stretching only ligaments of the posterior capsule, and you may need maybe 7 or 8 weeks of casting, particularly in the 5+ age group patient. And you will also notice that many of the children cannot walk on tiptoe after 3 to 4 months. This is a 23-year-old girl in whom I have done a tenotomy. That's under local anesthesia, no GA. Under local anesthesia, I do a tenotomy earlier with the number 11 knife and now with the number 15, all of them with the number 15. Don't go too far back. Number 11 tends to go far back. I've shown this just to show, don't use the number 11 line. It goes all the way back. It pokes at the back and you might damage the neurovascular bundle at the lateral side. Medial side, you're never worried. And in the older patient, you don't get the pop, you just get that little depression after tenotomy, nothing else. A little depression, you can feel it. So you know that the tenotomy is complete, that depression is there, and then weekly dorsiflexion cast. Same girl, 23-year-old, toe walking is possible because the tendon is regenerated completely. So don't worry about tenotomy under local in these older patients also. See the side view, toe walking, good regeneration, full thickness regeneration of the tender Achilles is there. In the older child, we also don't have an answer for bracing. In the older child, we give a foot abduction brace in hinged foot abduction, in a hinged ankle foot orthosis for the child to go to school, and a foot abduction brace when the child is back from home. Only to school. People like Monica Naguera in Latin America, she says no AFO will work. You have to have a foot abduction brace, and she puts the child in a wheelchair, gives a wheelchair to the child, and gives the child a foot abduction brace. That is the best method for correcting and maintaining the correction of these children, not an AFO. A hinged AFO maybe for school going in India, but otherwise prefer the foot abduction brace. And they may not tolerate 70-degree abduction. You may need to reduce it to 50-degree of external rotation. Adherence to bracing may be a problem. Even when given only at night, there may still be a problem. We have to negotiate. And when the parents come every night, he is taking it out. Then you have to tell that parent, what does he like to do? Does he like to watch TV? Does he like TV games? Does he like computer games? Oh, he is very keen on that. I said, okay, he gets to do that only when he wears the brace, not otherwise. So negotiate with the parents, negotiate with these. So if necessary, you may need to do a tibialis anterior tendon transfer, look for dynamic supination and plan for that. Outcome evaluation, remember dorsiflexion and foot abduction both are important. So foot abduction may be restricted earlier than dorsiflexion. So that is a very good index to look for early recurrence. In some children, there may be a slight tendency for the great toe to be abducted, but that's okay, it's correctable. Follow-up, how long to follow up? My protocol for follow-up is, in the younger child, I call them every 3 months. In the older than 5-year child, I call them up 6 monthly. In the older than 8 years, I call them annually till they are skeletally mature. Do I get X-rays done? No, I don't get X-rays. What is my breakpoint for surgery? Syndromic club feet. Syndromic club feet. That's when I plan for surgery. 11-year-old girl came with the TA lengthening already done, had a TA lengthening scar. I started Ponseti. Don't worry about this callosity. This callosity will drop off. Corrected with Ponseti's method. No other scar other than the tenotomy scar. That can you see the scar? That's the only scar I've given her. Good toe standing, but only difference is the size of the foot. The mother wanted both feet to be the same size. That is an indication that you must correct these feet early on before the child starts walking. Unilateral clubfoot, Foot size difference is an issue. We have no answer for that. Foot growth has 3 phases. First 5 years, rapid growth. Then slow growth. Then at skeletal maturity 10 plus, girls a little faster than boys. Another phase of rapid growth. You need to understand. So difference in the foot size, you cannot correct easily. We have to remember that. So unilateral clubfoot, always be, so the callosity, can you see this callosity? Huge callosity is there. It will drop off, corrected by Ponsati's method. Only no scar other than that of tenotomy. Can you see that? Callosity is there, it will drop off, it will become normal skin. There is no scar. Can you see the middle side of the foot? There is no scar in this child. It's fully corrected, valgoid foot, abducted foot. Can you see this? This callosity will drop off. And that's the only scar I have given. Nothing else. But the size of the feet are different. Bilateral, but that's not an issue. We correct it, beautifully corrected. We have a tendon transfer that has been combined in this, and the child is doing well. So remember, short-term results are good. Older walking patients, whatever I have seen, long-term results are also good. Osteotomy, I do only for neuropathic and secondary on tendon transfers for secondary club feet. For arthrogrypotic feet, these are the children severely deformed arthrogrypotic syndromic child. I may use these external fixator. A neuropathic foot with trophic ulcers, I may use total contact cast, followed by maybe an arthrodesis to get a foot cosmetically corrected, good correction, so that the plantigrade foot, the child's sole of the foot can touch the ground. Then we know that Ponsati's method, even if it fails, the magnitude of surgery is less even in a syndromic child. Thank you very much.
Thank you, sir, for the exhaustive talk on the club feet in the walking age group. So we have a few questions in the chat.
Yeah.
So is the Paver score for relapse clubfoot more accurate than for assessment of the relapse? Paver, PAVR.
Yeah. So if you have any of these scores, there are any number of research mode, you can use any score that is there. You have different scores that are there. You may use them. It's only the convenience and the time that you have to do in a busy clinic that creates a challenge. So there are so many other scores. I have not named any of them, but you have them. You may use them for research mode, but on a public health scaling up model, that is where I use the Pirani score. It is simpler, easy to do. So I pick up recurrences by just looking for the foot abduction and equinus, nothing else. Get the child to squat and get the child to sit, and I check for abduction and passive dorsiflexion. I know this foot is recurring.
So the time duration for changing the cast?
Weekly.
Yes.
I have to explain that it's weekly. You don't need to make it 2 weekly in the older patient. It is weekly because the logic given by Ponsati for weekly cast was, he said there is a retractile fibrotic tissue with an abnormal collagen on the medial and the posterior part of the joints of the clubfoot child. This tendency for the retractile fibrosis tissue remains till the child is 4 to 5 years. That is why after this, the recurrence rate goes down, but it is not zero. The retractile fibrosis, you can stretch it, but it has a crimp that allows the stretch. The crimp is like the crumpling of the cloth. That's a crimp, which allows the cloth to stretch. So this stretching that you do in the first week, the crimp reappears on the stretched mode. That's the natural growth. So it crimp reappears. It is there in 5 days or so. So that's why even if it is accelerated Ponsati, you need to give 5 days for the accelerated Ponsati to have the crimp coming back for restretching. That's important. You can't do accelerated Ponsati everyday cast. No. It has to allow for the crimp to reappear to be restretchable. So weekly cast is convenient. It allows the crimp to come back to allow it to be restretchable. Unnecessary 2 weeks, prolonging the period of treatment, doubling the period of treatment time.
Thank you, sir. Sir, another question was before tenotomy, below knee walking cast, can it be applied?
Well, in an older child, you may do it occasionally if you feel that you can mold the foot correctly. In a severely equinous feet, I would not recommend that. If it is equinous feet, as the foot is getting corrected, the cast will slip. Please put an above knee cast. If the equinus is not severe and the plaster is not like to slip, you may try it, but I don't routinely recommend it. Always prefer an above knee cast, but you may reduce the degree of flexion from 90-degree flexion to 40-degree flexion.
Yes. So another question was why most of the club feet are seen in economically constrained people and not so in the affluent society?
No, there is no affluence-based difference in variation. In fact, if you look at the population studies on club feet world over, like in Scandinavia also, the last study that you look at in Scandinavian studies are very reliable. Why? They have the social security number, like our Aadhaar card number. They have the social security number. So everybody anywhere in Sweden goes to a hospital, a social security number is accessible, and every detail on that child and every X-ray, everything is there on the record. Accessible like Vigi Health that we are planning. It is accessible. So good records are there. They found the average, the incidence is about 1 point odd per thousand live births. Is it in India too? India is also 1.2 per thousand live births. But in Polynesian islands, where the population is likely to be consanguineous in a larger number, the numbers are much higher. 7, 8 per thousand live births among the Maoris, Polynesians. So it's nothing to do with the poverty. The untreated, so-called neglected club feet that you tend to label, the untreated club feet are there in much larger number in the poorer community because of access issues. They are not able to access the treatment methods that the rich and the middle class can afford. And therefore, they have more untreated club feet, walking children with club feet than the other one. But the incidence is more or less the same. Studied by Ruth Wine Davies and Exeter in UK, southern UK, England. The incidence is almost the same.
Yes, sir. Thank you, sir. So another question was, so do you do anything for the residual metatarsus adductus?
Metatarsus adductus is a completely different diagnosis. To call it metatarsus adductus, which is I'm coming to that. So I would like to call it forefoot adduction, not metatarsus adductus. So the forefoot adduction, if there is there, I would do a serial casting and that's it. I don't do metatarsal osteotomies, no.
Yes. So
I do
Professor,
abduction cast
yes, sir.
and abduction brace.
Another question was, can a foot abduction orthosis be changed to a CTEV boot for school-going children if
No. Doesn't. So the principle, please remember, please don't make that mistake. A CTV shoe is based on the principle of pronation of the foot. Ponseti's method is based on the principle of supination and abduction of the foot. You need abduction, not pronation. Please don't ever give a CTV shoe.
So one last question was, what factors to be checked in long use of foot abduction orthosis or boot?
Yeah. So a large number of children are there with vitamin D and calcium deficiency. Some of these parents may come back to you saying with ये brace डाला तो इसमें knock knees हो गए हैं. So watch out for vitamin D deficiency in these children. Knock knees don't normally happen as a result of this, but you can watch out for these things. Otherwise, there's no issue.
So, on an average, how many casts are needed for untreated ones after 6 years?
Untreated after, most of them get corrected in 10 to 12 casts. Occasionally 13, 14.
Yes. So, and all of these are without anesthesia in the outpatient only?
All of them in the outpatient, sir. You can come to my clinic and see.
Yes.
All of them in the OPD, all of my tenotomy is in the OPD. I don't take them to the theater. It's
Yes.
all under local. Whether it is 3-year-old, 5-year-old, 10-year-old, 15-year-old, 23-year-old, they're all in the OPD.
Yes, sir. So thank you, sir. So as of now, we don't have any more questions. So I think we can conclude our session today.
Thank you. I hope it's useful.
Yes, sir. Thank you once again, sir, for joining us today. And
Okay.
we'll have another session next week on tarsal coalition. Thank you, everybody, for joining. Have a good day. Okay, sir. I'll conclude the session now.
How many people were there?
Sir, maximum count was 30, sir. Average was 27 to 30 in that range. So it was live streaming on OrthoTV channel, YouTube channel. So it will be there on their channel for later viewing also, those who could not join.
Okay. Thank you.
Okay. Thank you, sir.